And welcome to today's OR-SPD webinar. Today we are joined by Surgical Solutions, Robin Evans, Clinical Nurse Specialist Manager, and Adam Smith, a Clinical Solutions Specialist. OR-SPD would like to thank our sponsor, Surgical Solutions. Based in Overland Park, Kansas, Surgical Solutions is a trusted leader in on-site surgical support services, specializing in non-clinical surgical services, staffing, and sterile processing. They deliver tailored solutions for a broad range of surgery centers. So for more information, please visit surgical-solutions.com. Now, today's webinar is eligible for one continuing education hour from the California Board of Registered Nurses and also one CE credit from the CRCST. So you can obtain both certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificates, and you'll be able to download both of them directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Now, just a quick reminder that OR-SPD is pleased to support the Southeast Councils of Perioperative Nurses Conference, which will take place on November the 14th and 15th at the Hilton Beachfront Resort, Hilton Head Island in South Carolina. So please join us for perioperative professionals for CE accredited education, exhibits with leading vendors, and of course, great networking events. For more information and registration details, please visit southeastperiop.com. Let's kick off today's webinar by giving away one of our OR-SPD lunch bags to the attendee that can tell me the answer to the following trivia question. May is Lupus Awareness Month, so what colour is associated with lupus awareness? Answer now using the questions feature on your dashboard, and I'll reveal the winner and answer at the end of the webinar. We'll have a live Q&A at the end of today's presentation, so please submit your questions anytime using the questions feature on your dashboard. Now, as I mentioned earlier, our presenters today are Robin Evans and Adam Smith. So Robin, you may begin whenever you're ready.
Well, thank you, Linda, so much, and hello to all of you. Today, we're going to focus on something that's becoming more visible in surveys: hidden compliance risks between the OR and SPD. These are always policy. There's always policy gaps. More often, there's breakdown, inconsistency, communication, and workflow execution. Our goal today is to help you recognize where those risks live and give you practical ways to fix them. A little bit about myself. I've been a nurse for 32 years. I started in the operating room 31 years ago in Illinois, community little hospital. I've worked my way up from the very bottom. So when I started, we didn't have scrub techs, so that tells you how old I am. It was all nurses, and so I worked as a scrub, and then I became a circulator and worked my way up. I've been in leadership now for the last 20 years. I've traveled about 10 years of that as an interim manager director, and I've done all sites of nursing in the operating room. I've done critical care hospitals, trauma hospitals. I've opened a few surgery centers, and I've been with Surgical Solutions now for the past year and a half. I love it. I think the biggest passion for me is I want to give you guys the tools that you need to be successful for all of these surveys and to build that gap between all of our perioperative services. And I will hand it over to Adam.
Hello, everybody. My name is Adam Smith. I'm a clinical solutions specialist with Surgical Solutions. I've been in healthcare for 20 plus years. I got my start in food and nutrition services and nutrition management. And most recently, within the last 7 years, started leadership in sterile processing department. 20 plus years total in healthcare, but 5 years total with Surgical Solutions. And here at Surgical Solutions, you know, we do there's a lot that we do and are able to do. But one of the main things that me and Robin do is we observe workflows within the perioperative environment. We partner with hospitals, observe workflows, identify gaps, whether it's communication gaps or workflow gaps, to bottlenecks within the department. And we also like to make sure that our partners are compliant, completely compliant and ready for survey. So that's something else that we do. We like to do on-site assessments and find the gaps and inefficiencies within our partners and help them to resolve the issues. So with the Accreditation 360, this is a completely new way of thinking. And just to touch on a few things that we're going to talk about today, that there's been a complete shift in the way that these surveys are conducted. They've rearranged policies. You'll hear a lot of talk about, well, they've removed some standards. The standards have not necessarily been removed, but they've been kind of rearranged, and their approach on how they survey is completely different. They are spending less time on policy binders and more time on the front line. They're observing processes, they're interviewing staff, and we're gonna help you guys to help your teams feel comfortable with those surveys and that survey process. And so that way, when you have your next Accreditation 360 survey, you and your teams are both ready for that. Do we have any questions so far? You can put those in the chat, or if you have a question that you want answered now, we can answer that at this moment. Okay, it's off to you, Robin.
All right. So standards were not removed. So the new Joint Commission Accreditation 360 program is one of the biggest changes in healthcare accreditation and survey readiness in decades. It was officially launched in 2025 at the end of 2025, and it's become effective in 2026. The overall goal is to move healthcare organizations away from checking boxes and managing binders and towards demonstrating measurable patient safety and quality outcomes in everyday operations. So yes, everyone thinks things were removed, but what was removed from 360, from Joint Commission 360s was the requirements were removed. So they started removing requirements back in 2023. And then some of the standards have been restructured. I can honestly tell you the biggest one that has the restructure is infection control. So infection control got a lot of standards put underneath them, and that is going to be the most heavy hit in your facility, will be infection control and life safety. That is what I've been seeing for the past 6 months, and we can talk about that throughout this survey, but I just wanted you to know. Also, I'm very excited to see the national performance goals. As you can see, us nurses, we got a couple new goals out there to prevent workplace violence and patient safety, and then staffing levels for appropriate care. That was very exciting to me. So Joint Commission does hear and does see that we are working, at capacity, and that we need protection with the workplace violence. So that was very exciting to me as a nurse. I was excited to see that. In the real world, surveys are going to ask members and team members to demonstrate the proper use. So I can give you guys several examples. One of the examples in SPD is they had asked one of the team members, where's your fire extinguisher? And they were like, oh, it's right there. Well, how often is it checked? Well, they didn't know the answer. So I think that's where that's where the misconception is. So we have to give the tools to our team. So our fire extinguishers are checked every month from an outside company. Now, I want to stress this, it is every month. Now, it can be checked before the 31st day, but if it's checked after the 31st day, they will write that down as a violation, and then they will check throughout your entire hospital if you had any other findings in any other departments. And if it's a repetitive offense, that will go up to a red mark. So just be mindful of that. So those are things that staff were not aware of. Another thing is they did ask, well, what do you do in a fire? What does race and pass mean? And do you know how to activate it? Well, what if there's a fire in SPD? What is your job? What do you have to do in that moment? And where do you go? So they're asking the staff this, and they're also asking vendors. So they are focusing on vendors, also not just patients. Why I think this is exciting news, because we're always focused on the patient as nurses and caregivers. but who's protecting the staff and who's making it safe for us to work also. So I think this is a good thing with the 360, because they are looking out and making sure that the staff understand the process and the vendors understand the process as much as the physicians, patients, and everybody else that's getting taken care of. So that was one of the examples. Unfortunately, they didn't know that the fire extinguishers, another one was the eye wash station. Who checks it? Whose responsibility is it? How often is it checked? What's the temperature? And if you get something in your eyes, how long do you have to flush your eyes out? These are questions that we are physically seeing, and I have absolutely observed. So I just want you guys to be aware, this is all life safety and infection control. And that's why I said that is one that is hit very heavy. Point of use care, that's another one that's been hit a long time for me as an operating room nurse. I've been dealing with that for over 20 years. But now it's not just a point of use, they want a process, and they want everybody to understand the process. And I mean everybody. So if you're doing a bedside procedure in ICU, your nurses better understand what a point of use care is, why you're spraying that instrument, and do you need to document the time that you sprayed that, like your endoscopes. You better have a defined method of what time you did that point of use, have that time on there, so when they get processed, we all know delayed reprocessing is huge right now, and if it hits that 60-minute mark, that is a totally different way of reprocessing endoscopes. So this is a huge thing throughout. I understand there were some questions about point of use care. What we've done in our facility with all our partners in surgical solutions, so we specialize in the perioperative setting. We've made it a point that, if I have a scope on it, they're going to write the time of the scope when they did the point of use care. Everyone has been trained, staff in the operating room, endoscopy, cath lab, urology clinics, if their clinics are coming over. So that is one of the main educations that we're doing, is making sure that the staff is aware that that time is very crucial for us to prevent a delayed reprocessing, which will take that scope out of service for over an hour, depending on your IFU for those scopes, because they have to soak an extra longer time because we have to manually clean them. So that is one thing I just want you guys to be aware of. Another thing is following IFUs, or you guys have all of a sudden you get a new product in the operating room and you're like, oh, that's a new product. That's not even what we use. Or in SPD, we get a new gown. And I'm like, well, did anybody look up the IFU if that's, can we use that? Is that compatible? Or we get a new piece of equipment and it's a totally different IFU that we can't even do in our department. So be mindful of that. IFUs are changing on a daily basis. I honestly think it could be a full-time job for somebody at a hospital or at a clinic, because they are changing. And you don't get notification when an IFU comes. And I can tell you, supply chain gets all of these equipment in or supplies in and cleaning supplies, and they do throw all that paperwork away if it's a new supply. We don't get that. We just get the product. So be mindful and teach your staff to be mindful to look if something new comes in. Please get on one source or try to find that IFU before it's used. Those are some things, just like lint-free. So here was another incident, OR nurses, OR people. Our surgical solutions person was walking down the hallway and two people came out of a room and they had x-ray gowns on. And the surveyor said, so how often are those x-ray gowns checked? Well, we wouldn't know because we're not there, but they asked us anyways. So thank God, our team knew about this. So x-ray is responsible for checking the x-ray gowns in the operating room. They're checked every 6 months. But the biggest question was, well, how often are those washed? Or how often are those rinsed? Or how do you clean them? So I can tell you, x-ray gowns don't get wiped down every single time, but that is a requirement. It is in the IFU, and you need to make sure you have the proper cleaning solution. It's not the PDI wipes, it's actually a hydrogen peroxide wipe. So these are things that people don't know. And this is what we like to do. We like to educate you on the proper cleaning supplies. So just be mindful, give those tools to your team, come up with scenarios and give them everything they need, and they'll do great. And I think the biggest change for the Joint Commission is it's called the show me approach. It's becoming more important than tell me approach. This will particularly be important for the workflows for HLD, probe reprocessing, sterile processing, environmental cleaning, competency validation, infection surveillance, equipment maintenance, and IFU maintenance, to name a few. So those are the big changes with the 360 Joint Commission. Adam, I'll hand it over to you.
Right. So, it's all about how we handle. It's inevitable that things are going to come up. We're firefighters. We should have our little firefighter hats along with our scrub caps. Things are going to come up. This Accreditation 360 process is, the surveyors want to understand that we know that management knows the proper process. We know that they know what needs to happen, but they want to know that the front line knows how to handle a process and what that process looks like. We've all been through surveys before where, that old visual of the surveyors in the conference room with stacks of binders, all your policy binders. Oh, I need this binder, I need that binder, and we're running back and forth with all these binders for the surveyors. They're moving away from that, and they want to see it put to action. You could have the best written policies, you could have the most immaculate policy manual in the world, but if your staff can't show the surveyor how it's done, then it plants a seed of doubt. Scenario, let's say the surveyor goes to a scrub tech and they ask them, what is your process if this tray arrives wet or contaminated? And then they go to the SPD tech and they ask the same question. The answer should be the same. Your scrub tech and your SPD tech should know that process. We all know when things go wrong, it's not necessarily, the focus always is on SPD or the OR. It always falls on us. We're the front line. We're the ones that are going to catch the majority of it. But we know when things go wrong, it takes a village. It takes many departments. It takes many different management groups aligning on a process and what that process looks like. They want to know that your team can speak to what their responsibilities are, when the situation needs to be escalated, and who owns that next step in the escalation process. So, have your policies. It's very important that we have those policies and that they're written well and clear and concise. But we also want to know that our teams can speak to them on a regular basis. Any good workflow is going to have a set of actions. It's going to have a specific order that is supposed to take place. There's going to be a clear sense of ownership and what information needs to be relayed in that process. So when a surveyor is going to ask, show me how this works, or why are you doing it this way? So we should be having those kind of conversations with our teams as well. Like random throughout the week, walking through your department, making your EOC rounds, stop by and just randomly ask a question. So what do you do if, or why are you doing it this way? Because the answer to those questions are just as important as just them saying, well, it's supposed to be done this way. Well, they want to know why they're doing it that way. They want to understand. If your teams can tie it back to a real life scenario, they're going to remember it a lot easier. We don't want to wait till competency time to make sure that our teams are competent. We know that our teams know what they're doing. It's more about getting them comfortable with being put on the spot. We know that our teams know what needs to take place. They're used to running around in the flames and putting out fires. But can they answer that question when they're put on the spot? So I find that just having those random stop-ins and randomly asking these questions throughout the year. Another method that I've seen that's been really successful is the scavenger hunts. Doing the scavenger hunts with the fire, Robin mentioned the fire extinguishers and the acronyms, the ones that we always whip out and dust the back of our badges off and look at during competency time, or those annual modules that we have to do, race, pass, those kind of acronyms. Do fun things with your teams throughout the year. Scavenger hunts, like I said, is one of my favorites. The teams always have fun with that, because when they can tie it back to reality, it's going to be second nature when that question comes up. They're going to know how to answer that question. They're going to be able to be comfortable with the verbiage that's used. And I think that is on to you, Robin.
All right. So some other great changes with the Joint Commission 360 is they started this program called SAFEST. It's Survey Analysis for Evaluating Strengths. What I really like about this, it's a program that Joint Commission identifies the strongest processes and spreads those insights faster. So we know that our surveys are stressful, and instead of simply breathing a sigh of relief that you passed, now your organization can be a model for the industry. So like if you're going for a magnet status, this would be absolutely amazing on this. Here you are promoting your excellence on Joint Commission readiness, survey readiness. You've got a great score, and Joint Commission will work with you throughout the entire year, and you send in things and they'll help you rebuild it so you can promote best practices. It's human nature that things are working because you haven't had any major issues until you have little wins all the time until something major happens. So the bottom line is you can't be survey ready if you're not actively validating your processes. So that's why I said be ready to answer for the survey to see how it works. The Accreditation 360 continuous engagement and continuous readiness, the surveys are expecting to evaluate whether safe practices occur routinely, not just during the survey preparations. This will require facilities organizations to develop stronger and more consistent audit systems, surveillance systems, competency tracking, electronic documentation, traceable systems, and quality metrics. This also creates a strong argument for automation and electronic documentation. That is a huge thing. They are literally watching from start to finish. They will actually ask you to pull up what you did the day before in SPD and look at one of your trays, and they want you to be able to track that tray from when it got processed and where it went and how it got back to you. So that's where electronic tracking is going to be very, very, very important, and the changes that can help us. So some real life examples. Can you show me what impacts the possession, the possibilities? So I think what's exciting for me is all of our organizations, like ARN, SGNA, and HSPA, they're all getting in alignment right now. So all of our manuals, our standards books are in the process of being updated. I know I know right now ARN is actually changing a lot of policies, and it's kind of funny because some of the standards are going back to the old way when I first came out of nursing school. They're going back to the way I was actually taught. But what I like about it is they're all aligning as the same front. So perfect example, right now in some of the policies, it states that you can hang your scopes vertically or horizontal. But if you pull the IFU, the scopes have to be hung vertically. So all the IFUs for the endoscope say they have to be hung vertically. And so I believe all of those standards from all of those three organizations, they're going to take out the horizontal, that the scopes cannot be horizontal. And I know that's going to freak a lot of you out because you may have the Medivators, Steris things that are horizontal, but I'm just letting you know that will be possibly coming down the pipe, that all scopes need to be hung vertically. So that's exciting to me because now they're all talking to each other and we're all going to be coming in a line. So weekly reviews, another thing that we can do to help prevent issues or fix issues is daily huddles. So I have daily huddles every single day with my staff. I like to bring SPD, but I like everybody involved. So I need the OR-SPD, everyone that's involved in it. So we have what happened today, what was missed today, what could we have done better, did we lose track of something? And then I like to do forecasting. So I like to do a week forecasting, and this can help you look at your schedule a week out and just say, like, you know, what's today? Thursday. So Tuesday, we noticed we have 5 cases, but we only have 2 trays. Can we move some of these cases around in the operating room? Can we change some times? Or I only have 2 C-arms, but we have 5 cases and 4 of them are going at 7:30. So we need to realistically look at your forecasting to see how it's going to help you flow smarter and not cause that bottleneck up in the operating room. So these are things that I like to look at. And then back order items, like I talked before, you don't know what's back ordered and you just get a supplement of a item. And the biggest thing right now is lint. So lint is a huge issue in SPD, and it's a huge issue in the operating room. It's in our trays. And I can tell you right now, it's really being talked about and it's getting cracked down that you have to have lint-free cloth in SPD, in the decontam, SPD side, prep and pack side, throughout the entire where you're doing any type of procedures. The lint is actually getting in and it's actually damaging your equipment. It's damaging your washers. It's damaging your sterilizers, and it's getting into your trays and contaminating your trays. So just be aware of certain things. Like I said, I would love a person to have a full-time job just looking at IFUs. So that's basically where I think it brings you back to looking to see how we can make it better and find our shore points right there during those huddles. And when you're doing those huddles, you can do your joint commission questions, the EOC rounds. I think if the staff is aware that you're not going to get in trouble. We never got in trouble in the past. You're not getting in trouble now. I think if you can give them the tools, I think they'll be really nice and relaxed because they know how to do the job. They just need to be able to speak that process. And I think that's the biggest focus on this Joint Commission 360. All right, Adam, up to you.
All right, so you know, just to cover a couple of things that we've already, you know, talked about, just to kind of round things out. You know, the biggest takeaway is going to be consistency. We want to make sure that we have that consistent language across departments, and you know, those huddles that Robin mentioned, those weekly forecasting, daily huddles, those are going to be a good way for you to preach that consistency, really drive it home with your teams, and make sure that everybody's on the same page, because they're going to want that consistent language and across your teams. The policies, you know, we mentioned that they've moved away, you know, from just reading your policy manuals and started actually observing the real life situations. That being said, you know, you want your policies, your policies obviously need to be strong, they need to be good, but your policies need to match your real life scenario. So if you change a process, your policy, you need to check your policy and make sure your policy doesn't need to be updated with it, because if they don't match, then that's where we talked about the consistency. It's not going to be consistent. So if you change your policy, you're going to have to change your workflow. Or if you do it in the opposite direction, if you change your workflow, you need to make sure your policy is updated to match that workflow. And then, you know, going through and having those regular conversations with your teams, and just getting them comfortable with being put on the spot. That's the biggest thing that I have. You know, it becomes a culture within your facility, and you know, before you know it, you'll see your teams quizzing each other. They kind of have fun with it, and that's how your teams get more familiar with it, is when you make it part of your culture, that quiz culture or that trivia culture. Just randomly putting them on the spot. They're not going to like it at first, but they get they get comfortable with it and it becomes a second nature, and they'll be looking forward to it. Oh, I hope he calls on me this time. I know the answer to this one. So, you know, that's the kind of culture we want to breed in our facilities to make sure that we're all comfortable, and we're comfortable not knowing. Like, our teams need to be comfortable with saying, okay, I don't know that. Let me find out, or where do I find out? And having an inquisitive nature about them. You know, we want our teams to be able to have the resources to look up the things that they don't know. So that's just as important as what they do know. We want to understand what they don't know, so we know where to guide our education sessions, or our quiz sessions, or our huddles. We can pivot and guide our conversations and huddles in the direction that they need to go in, because we understand where the gap is with our teams. And, you know, just as one last reminder about you know, us at Surgical Solutions and what we do, me and Robin are very passionate about compliance. We're very, very passionate about patient safety, employee safety, and how it affects our teams and our facilities. We partner with hospitals to help bridge those gaps. We find those bottlenecks in the workflow. We find those communication gaps. You know, it's a tale as old as time, like the finger pointing. Something goes wrong. We've seen it 100 times, million times even. You know, there's a contaminated tray on the sterile field, or a missing indicator, or a situation is not right with a tray. You know, that's when the fingers start flying and pointing at each other. We want our teams to have the resources and the tools they need to be successful, and how to handle those situations when they come up, and not having to figure it out in the heat of the moment. We want them to know it like the back of their hand. And that's where this Accreditation 360 process is at. They want to know that our teams can function without leadership breathing down their neck. I mean, you never know what situation may happen. I might be sick this morning and I can't show up to work, but does that mean the OR should fall in disarray because I'm not there for that day? I need to provide my team with the tools so they can be successful without me. And that comes with knowledge. Knowledge is the key to success in anything that we do. So here at Surgical Solutions, we like to teach those tools to our teams and our partners, find those bottlenecks, find those gaps, put our heads together and collaborate on a solution to bridge those gaps, and to help our partners put out those fires with minimal hiccups to their operations. We want them to focus on patient care. Patient care is the reason why we all have a job, and it's what we do. So keeping the patient at the front of your mindset and your team's mindset always. It's not about who did something wrong or what was done wrong. It's how does this affect the patient? How does this affect our core customer, which is our patient, and that patient safety should always be number one. So we like to take that off of our partners' plate, handle those fires for them, bridge those gaps for them, find a solution, and let them focus on patient care. Do we have any?
Thank you. We'll answer some questions now.
Perfect. Yes, we have had some come in. One's referring to your section about misconceptions about standards. Why do you think there's so much confusion, and what have you heard when we're working with hospitals?
So I've been in several surveys. It's not so much, I think something got said that they removed standards. They didn't remove any standards. The requirements got removed, like I said, in 2023. What's happened is they've reorganized standards and And as I said, a lot of it went underneath infection control. So infection control is has a huge umbrella now. A lot of environmental care, life safety is all under infection control. I don't know where the misconception came. I think it just kind of trickled out by, people just kind of said, oh, it's going to be easier. It's not going to be easier. Their rationale is, we're here and we want you to know it. We want you to be prepared. We don't want you to come in and get ready 6 months prior. We need you to practice this throughout the entire year, every single day. So I think that's what they're trying to focus on, is everyday survey readiness, so your processes match what you're giving out in your care.
Oh, perfect. Adam, have you got anything to add to that before I jump to the next question?
No, I don't. I don't think it. I think it, like Robin said, I think it's just mostly, it's a perception, and we're in a small world. It's big. The medical industry is huge. The operating room is a huge business, but it's small at the same time. So that trickle down effect, that that word of mouth, that kind of gets going, and it steamrolls. So somewhere down the line, it was mentioned somewhere along the line that it was going to be easier, like Robin said, and so then it's kind of like spread and spread. So we've been experiencing, everything that we've mentioned today are real life experiences. This is what me and Robin do, on a regular basis, and this is stuff that we've seen. Is they are under the misconception that it's going to be easier. They're not going to be writing our policies as much. They're not going to be, going through our stuff with a fine-tooth comb as much as they used to, and that's definitely a misconception. And if you have the inconsistencies, the real life scenario that I gave, where if they ask the same question to the scrub tech as they do the SPD tech, if those answers are different, that inconsistency actually makes them dig harder. They are going to do a deeper dive. I've seen them open every single variation of the same tray because they found one that was inaccurate. So they opened all 15 trays. So, they noticed the inconsistencies. That's a red flag for them. That's why I mentioned, the comfortability with this type of conversation throughout the year. So that way we're ready for those hard questions.
Great. So what's the biggest gap you've seen between what staff know and what leadership thinks they know?
Oh, well, I could do a lot. So I can speak from our contracts and where we're at right now. So this is up on the East Coast, just so you guys know. I was at 4 surveys, and I think the one that surprised me the most was the surveyor opened up 15 trays. So I've been doing Joint Commission forever because I've been a nurse for a long time, and we only opened up 2 or 3 trays. He opened up 15 trays, looked at all the instruments. They're looking at divots, they're looking at grooves, they're looking at rust, and he wanted to know the process. Well, why is this in here? This has got a groove in it. Well, if it's more than a millimeter, you have to discard it. Well, we don't discard instruments. We have to be aware, yes, if it's got a groove in it, or it's got a divot in it, or we do have rust and it's not removable, we send it out for repair. That was what he was asking the staff about. What is your process? And he said, oh, you have to discard it. And they're like, yeah, we just throw it away. That's not the answer. The answer is we do have a process. We put it in our repair bin. It goes out to our repair company. If they can't fix it, they send it back and say non-repairable, and then it needs to be replaced. And I think leadership thinks they know because, okay, you have a supervisor or you have a lead. So what I've done since all of this happened at the end of last year and this year, I've made some great tools for Joint Commission for our team. I know people are like, oh, it's a cheat sheet. It's not really a cheat sheet, but it is for our team. It's a tool for you to understand. If you have a question, it's right there. Another question they asked in sterile processing is, well, what do you do if you have downtime? And the staff just goes, what do you mean by downtime? Us nurses know what downtime is. it's an IT downtime. But they literally asked an SPD tech, and he goes, I don't know what you mean. And she's like, well, what are you going to do if your computers go down? And they were kind of stuck. So I think they have to be aware, just because nurses know up in SPD, or up in the operating room, we all have to know. So if there's a downtime, first off, do you have everything that you're doing on your EMR? Because we want everything in our EMR. We don't want to be on paper anymore, but you've got to have paper to back that up. So do you have the right papers? It doesn't match your EMR. What's your policy on how many hours is it down? Do you have to put it back in? If you're over 4 hours, do you just file those papers that day? Or are you going to make the staff go back in and put all these in? So these were questions, real live questions. And another one that's getting hit really, really hard in SPD is the concentration of your enzymatic cleaner with your water. Okay, so you've got 10 gallons. Well, they want to know how many ounces is per gallon and what's the concentration. So, and we actually kind of had to do a little fight with our little surveyor because he said, well, it's on the bottle. Well, it wasn't on the bottle. There was nothing about a temperature or how much the temperature was for each ounce. So we fell back to our standards in HSPA. Our water temperature has to be 80 to 120, not to exceed 130 for our enzymatic solution cleaner. Most of the cleaners now have it on the bottle of what the temperature is, but this bottle did not. And so we had to show him, and he actually took it off because he did give us a violation for it, but we did defend it. So I'm just saying they're wanting your staff to understand the process of what you're doing. They want to know your daily checks. If you're coming in and doing all your daily checks in the morning, are you validating that the checks were done before you even run your first load in the sterilizer at 6 o'clock in the morning? So they're pulling these records. So I think that's the biggest thing that I've seen so far. You know, the downtime. Another one was, what do you do if you have a water failure? Where are you going with your instruments? How do you transport your instruments? So we do have a new transport policy out there and a DOT law now that everything has to be contained. It has to be temp humidity, has to be segregated, dirty to clean. Are you aware that that's out there? So Joint Commission is aware of all these new standards that have come out. Just like the scope room with your hanging your scopes. So it was recommended back in 2017 or 18 to get scope cabinets with air in their own area with their own temp and humidity, and it went into effect in 2023. So it's 2026, and there's still people that have not done that, and they are giving you a violation. So people do give you enough notice that standards are changing, and they're giving you time. Just like the water quality standard that just came out, everybody has to have an RO, critical water system. That's going to hurt a lot of people because we don't have the capital money to do that. So you do have a 3 to 5 year plan, as long as you're showing Joint Commission, this is what our plan is, this is the first step, the second step, here's the POs, this is where we're going. You can talk that process through, but that's why I'm saying I think a lot of people don't understand our standards are being met with Joint Commission also. I hope that answers your question. I probably went a little winded there, sorry.
No, it's very, very interesting. Got another question here about consistency and inconsistency. I mean, what causes the inconsistency in answers between departments?
I think it's that's a two-factor. There's kind of two different ways to approach that. One that's a huge one for me, and I mentioned it and I touched on it briefly, is the culture of being comfortable asking questions and not knowing. I think that is, you have to nurture that culture to get that, and it takes time to build. It takes time to build that trust, but building that trust within your teams so they communicate effectively with each other, that is where you get that cross communication, that cross training, that ability to speak to that full process, that 360 process. You know, it goes full circle, 360 degrees. That's why it's called Accreditation 360. you know, we expect that if you go to SPD and you stay within that SPD bubble, that SPD is going to be able to answer SPD questions, or that the OR is going to be able to answer OR specific questions within their bubble. But the reality is those two bubbles are under one umbrella. So everything under that umbrella needs to be able to speak to the same process, not just each individual department. So that's where that interdepartmental collaboration, interdepartmental meetings, huddles, and they don't have to happen. You know, it's not feasible necessarily that you're going to be able to get infection prevention, SPD, OR, EVS, biomedical, all in the same place at the same time every week. I mean, that's just it's unrealistic. We know the environment that we work in, what our hospitals and surgery centers look like, and we know that that's not feasible. But that being said, I think those meetings do need to take place, and they need to take place on a regular basis. You could schedule them a month, 2 months out. Even like having them on set days and schedule it out the whole year or 6 months at a time. But those touch points interdepartmentally build that habit, build that culture of comfortability with other departments,
Yeah.
and that culture of collaboration. And
yeah, I was going to say the exact same thing, Adam.
yeah,
Education, I believe education, ongoing education, but in a leadership role, I do truly believe having weekly meetings or monthly meetings in your area. So like if I'm the peri-op director, I'm going to have a meeting with my OR manager once a week. I'm going to have a meeting with my SPD manager once a week. There's got to be some communication. I can tell them my gaps that I see, they need to tell me their gaps that they're seeing, and we need to work together to come up with a solution together as a team, not a finger pointing. And of course, we always blame anesthesia for everything, so it's going to be anesthesia's fault anyways. But that is where I see it as a leader. I believe you really need to set up meetings with your leaders, your supervisors, and then that way you all can communicate. Well, this is what I saw that happened today. You know, we were missing this, this, and this. And if there's no communication, because I might not hear about it for 3 or 4 days. I can't fix what happened 3 or 4 days ago if I don't get told about it, or there is no communication. Same with SPD. If the manager doesn't know that it happened today and they find out about it a week later because they're in the hallway passing and a doctor says, hey, thanks a lot, I had to cancel my case because I was missing my trays. Well, I didn't know about that. So I think communication, and having some meetings set up with your leaders to make sure that you're communicating, and that will help prevent a lot of those deficits.
Yeah, and you know, Robin, we talked about, you know, the specific types of meetings, you know, those daily huddles within your department, but also the interdepartmental ones. You know, that level of communication is going to open up so much more possibility for things to get done. If you don't, I had a mentor tell me one time, and it stuck with me the most, was what gets measured gets done. And if it's not getting measured, it's not going to get done. So if you're keeping it as a task and something that needs to stay at the forefront, if you're keeping it talked about, or you're keeping it moving, it's gonna get done. Yeah. Because you're gonna keep mentioning it, keep bringing it up until it is. So just that, building that level of comfortability, talking with other departments is the biggest one I've seen.
Yeah.
Perfect. Another question here is, how can I make the case we should track our processes more when we're already stretched so thin?
Yeah, that's a great question. Unfortunately, you know, we've been doing it without for so long. We don't have the staff now, but we're making it happen. So of course, the administration, the C-suite, well, you did it, keep going. I totally get that. I think you have to look at this is just for me on with our company. So we have a role that we have an OR liaison role, and those staff members are the gap between SPD and OR. They're making sure your case cards are taken care of. They're making your add-ons, making sure they're up in the operating room, making sure that you don't have to run from room to room. I think if you can get a little win in there, rather than hiring another, I mean, granted, I would hire nurses if I could, but they're saying we already have enough nurses. I would hire, I don't call them little people, but I call them below a nurse. They'll do 10 times more work than is necessary to help you. So I think looking at a different role for other people's jobs, or helping understand, hey, can you help us with this? So I know someone had a question about point of use. These OR liaisons, when they pull the case card out, they're making sure all of those instruments were sprayed at that time before the case cards goes downstairs. So those are their responsibilities. A lot of people don't even spray their instruments and they forget about them and they're out the door. But I think just realizing, I totally get it. I totally understand. We have call-ins, we don't have enough staff, but we're always making it work until the time we can't. And I think once we can't make it work, then I think the C-suite's like, okay, what's going on? How do we fix this? And this is when you have to have the heart-to-heart and say, look, we've been running slow. We've been running like this for 2 years. We're getting it done, but my staff is getting 50 hours of overtime a week because we're having to stay past our normal time. And, you know, I think showing them on paper can also help. But again, we always make it happen because we don't want to let our surgeons down. We don't want to let the patients down. But we just have to think out of the box on how we can be creative with other roles to make things smooth, a smooth transition between our departments. And Adam can relay on that too.
Right. Yeah, I think that's you nailed it right on the head on that one.
Okay, great. I've got two very similar questions here about hanging the scopes vertically. One says, please can you provide the source of information about hanging the scopes vertically, especially for those of us with medivators? Another one is same thing. We are expanding and are looking at purchasing new scope drying cabinets, but they would be stored horizontal because that seems to be the best way currently. Where can I find data to support your statement that the standard could change to vertical only?
So if you have Olympus scopes, you need to pull the IFU because it literally states on the IFU for Olympus 190 scopes, scopes need to be hung vertically. And they have to be flushed with air for 10 minutes, not just in the aeration. When they come out of the aerator, it still needs to be flushed with air. So that's why we're going to those drying cabinets. But I did have to pull all of my IFUs because we did have we were doing some remodeling and they wanted to go with the Medivators. And I said, no, our IFUs for our scope state, they have to be vertically. I know in HSPA, it says vertically or horizontal. SGNA is supporting vertically now, and AORN is supporting vertically, and HSPA is under review right now, and I have a feeling they're going to take that out in our standard book. But the IFU for Olympus scopes literally states they need to be hung vertically. So that's where I would go. And if you're buying a Medivators, that's why they're trying to have you buy those cabinets, because they go in one. But I'm going to stress, please, please, please look at your IFUs, because it's done one way doesn't mean it's done the correct way.
Right.
Okay, we've got time for one more question. It is, what workflow changes produce the fastest measurable improvement without requiring major construction or capital spending?
I think that question is I mean, it's a really good question, and
Yeah,
it's
huge.
going to depend on your facility. It's going to depend on your workflow. We've all been out of several different departments and different facilities, and we all know that even though we have standardized practices and standardized processes, not every facility operates the same. So understanding that flow, that escalation flow for problems, and understanding that trickle down effect, or how your processes work, we find that the biggest impacts are not going to be construction or needing to completely restructure your entire department. Those are really, extreme scenarios, and very rarely does that even need to take place to notice a big change. The biggest change is going to occur with openness, communication, and consistency. So if you create that culture of openness, you create the habit of consistency, and then you implement all of that together, you're going to notice dramatic changes in your workflow and timeliness, the timeliness of how things get done. If you're tracking specifically the scopes, we mentioned the scopes. If you're tracking the scopes, if you're not tracking the bedside cleaning, the point of use cleaning, if you're not tracking that, you automatically have to assume worst case scenario, which would mean you have to go to the delayed reprocessing process. So that is a trickle down effect, right? If you would have implemented the quick process of just timing that when the bedside cleaning was done, that 2 seconds added to that workflow is going to save hours and hours of reprocessing time. Yeah. So knowing the impact of a little situation like that and understanding how to fix that within the workflow and implement it in a different way, or looking at it differently or approaching it differently, could make a lot bigger impact than if you tore your department down and then rebuilt it from the ground up. Does that make sense? I answered the question.
It does. Other things I see too is really looking where your bottleneck is and looking if you need to adjust staffing. I understand that doesn't come across very well with some people, and if you're a union environment, yes, you have to give the 30-day notice, but even just a little tweak. So let's say you're bottlenecking at 5, 6, 7, 8 o'clock at night, rather than having all your people coming in the morning and leaving by 4 or 5 o'clock, make a later shift, make an 11 o'clock shift, make a 2 o'clock shift in the afternoon so they bottleneck and stay till midnight. Or if you're doing 10-hour shifts or 12-hour shifts in SPD, just having that extra help when you have the most cases coming down in the evening, that can make a huge difference, because the turnover of all those trays, you'll see the next morning your case carts are complete. They have all their instruments. You're not having to wait for them to come out of the sterilizer. Literally looking at your staffing environment and how you have your staff can make a huge difference on your day-to-day operations too. And I did want to say one more thing about your IFUs for the scopes for vertically. We also follow ST79 and ST91. And I know it's in there if you guys have those standards. In the ST91, it's in chapter 11, because I think I've memorized chapter 11 by now, but I just want you to know it's also in our standards. So if you guys have a chance to just pull those, you'll be able to find that out about the vertical hanging of the scopes. But the IFU for the Olympus scopes does state that it has to be hung vertically.
Perfect. Thank you both so much for your time today and for such a great informative presentation. Now, if you'd like more information about today's presentation and sponsor, please visit surgical-solutions.com. Now, as promised, the answer to today's trivia question is purple. So congratulations to our winner, Beth Leonhardt in Indiana. Also, just a quick reminder, you can obtain your CE certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificates, and you'll be able to download them directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit OR-SPDWebinars.live for more details of all our upcoming webinars and complimentary registration. Also, just a quick reminder that if you've missed any of our past OR Today webinars, including any by Surgical Solutions, you are still able to view them on our website, OR-SPDWebinars.live. So thank you all once again for your time today, and I hope you enjoy the rest of your day.
Thank you, everybody.